So what I was wanting to cover here today was really looking at, again, looking at sort of the validation of biomarkers, and particularly thinking about patient selection tools or personalised medicine, and the roles in which we can use preclinical data from a variety of different sources, just in order to increase both the robustness and the confidence we have in these biomarkers within a clinical setting going forwards. So briefly what I want to cover today is just to briefly recap about personalised healthcare, and then just to consider what the implications are in terms of the development programme requiring a drug diagnostic co-development. And from that will sort of lead on to really the importance of phase 2 data in actual diagnostic development, the importance of that role. And then really to consider the way we can actually assist the phase 2 data in actually developing and using our diagnostics based upon preclinical data in order to really generate all the desirable properties, robust reproducibility, translation, credibility that we see listed at the bottom there. So I think another picture just describing personalised healthcare, what we've already seen today, but it's really about understanding those patients who will in some way preferentially respond to a drug or a treatment. And the really idea being that we have some sort of set of potential patients, there's some sort of diagnostic, and that will indicate whether a patient receiving a treatment will receive some sort of benefit from it or won't receive a benefit from it. And the real key part to this, the important part, is there's this combination in the middle here of the two parts, both the diagnostic and the drug. And it's really the combination of these two together which is what's useful and what's added value to the patient in the end. It's actually a very general sort of context. The real decisions around personalised healthcare can be based upon any characteristic of the patient or of the disease. Here I'm probably limiting a little bit. I'm really sort of focusing on molecular diagnostics. This is still a very wide area, potentially covering a whole range of different tumours or substrates we can be using. Biopsy, saliva, blood, CSF examples. You can look at a whole number of different markers going from DNA to RNA, proteins, metabolites. And there's a whole range of different technologies which can be used to identify these. And we can also be thinking about whether we're actually just using a single marker to make these decisions, or in some ways we're using what's called an algorithm with signature, a combination of individual markers to be able to make some patient treatment decisions. So just as an example of this, this is AstraZeneca drug for lung cancer, Iressa, or gefitinib. And I think this sort of really shows a very clear example of personalised healthcare in practice. So what we have here are the survival curves of the survival against time. And we have the gefitinib from the clinical trial in the dark line, and the lighter coloured line is the comparator, the standard of care treatment. And if we look at the left-hand box here, we're dealing with an EGFR mutation group. And here we see there's a very clear treatment benefit of patients receiving gefitinib above the standard of care. If we look over the right-hand panel, which is showing the complementary set, the patients with an EGFR negative mutation, we see again we're getting a very big split between the two treatments, but it's going in the opposite direction. So in fact, it's in some ways the standard of care is giving a better level of treatment than gefitinib. So there's some sort of clear interaction going on between the mutation status and the treatments in this case. And this is clearly demonstrating that the benefit both of having these mutation, be able to identify these patients who respond, and the drug, the gefitinib, which will really develop the patient benefit in the end. So, given the importance of this combination of the drug and the diagnostic, what implications does this have for the development programme going forwards? There's obviously been a number of thoughts about this, and this is in fact quite an early slide which was produced. And this really had a very simple idea that you had the drug process, discovery and development process, continuing on as normal, we're all very familiar with seeing. And more or less in parallel, we have a diagnostic co-development process going on, which is very much mirroring what's going on in the drug development process. And this is then neatly feeding into the drug development process at all the relevant times as we go along the picture. And I think this will be a great paradigm to use if life was simple and always was able to follow that sort of timelines. Unfortunately, I think we know it doesn't always do that. So what would be another way of looking at this? And this is sort of just, I guess, another view of this looking backwards. Again, we have the drug development pipeline going along here, from discovery through to phase 3 life cycle management. And essentially what we're looking for is that at this stage here, we're going to be able to register our drug in combination with a diagnostic, the patient population defined by that diagnostic. And what that means is we've got a registration trial going before that, which is going to be quite restricted. It's going to have to be quite specified in terms of what we're doing there, which means that going into the phase 3 program, we must have a pretty good idea of what our final diagnostic is going to be at that particular stage. So working backwards from that, it really means that by the end of the phase 2 program, which is going to be quite a comparatively small program in terms of population size, we're going to have to really look at that data to be doing, not only just to be proving the drug's utility as it normally would, but it's also going to have to prove a lot of information both about the biomarker and the diagnostic, maybe at the level of either just discovering the biomarker, or at least at certain levels of optimizing the diagnostic biomarker and proving the utility of the diagnostic at this stage. And what that really means is that we're going to be putting a lot of pressure and a lot of demands on this phase 2 data in order to get the maximum, be able to get this level of information out of that. And so what can we do to make that better? And the other aspect of this, just to be aware of, is the actual impact on the clinical trials themselves. Here's sort of a simple scheme of a typical standard clinical trial, that we enroll patients and we randomize them either to a treatment arm or to a competitor, placebo or comparator arm, and then do some sort of comparison at the end. Within a drug diagnostic situation, one of the goals or aims would be, if we got a well-defined diagnostic, we're actually able to run much more efficient clinical trials because we're not looking at this whole population. And this would be the idea down at this pre-selected area. Effectively, before we enroll patients, we apply the diagnostic and only enrolling those patients who pass the diagnostic form of the population, which could lead to a much more efficient clinical trial. Of course, we do always have the option of actually effectively running a standard clinical trial, but including the diagnostic in parallel with this, running an all-comers trial here, which will still allow to make comparisons between the different groups defined by a diagnostic. And in fact, would give us a lot more flexibility because we wouldn't be restricted just looking at those patients who've been selected by a first view of the diagnostic. We could look at various different other properties of the diagnostic or different ways of looking at that data to define other potential treatment groups and seeing if they gave more relevant comparisons or able to define a better group at this stage. So what happens in these situations is we really have this trade-off that in some cases we would like to be at a case where we could run a very efficient and quick trial, but that's very much dependent on having a lot of confidence that we've got the right diagnostic and the right biomarker to start with. And clearly we're running the risk there. We have that specified wrongly. We're going to not get the right sort of information. On the other hand, we could run things which are a much more exploratory trial by including really a lot of information here. But that has the disadvantages. The advantage that we're not going to miss everything. We've got a lot of confidence in the data. But the disadvantage that we're going to potentially more expensive trial to run, cover a lot more areas. So given that we want to use this phase 2 data, the gold standard, of course, is to have clinical response to treated patients to help in this phase 2 data, which affects what we're generating there. And prior to that, we're only going to have a very limited amount of that data, possibly what's coming out of phase 1 studies. So what can we use to actually assist that? One aspect is we have a whole range of in vivo and in vitro models we could be using from the discovery work. And the other angle we can use this is that we have various tissue samples representing the type of samples we're going to be using in the diagnostic. These are going to be undosed, not related to the actual treatment themselves, but will still give us valuable information about how the diagnostic will perform. So thinking about the diagnostic, what's the sort of things we want really for this to have? We really want it to be delivering, clearly want it to be delivering the right results. We want to be identifying the right patients. That's based upon it having the right science and measuring the right thing. We want to be doing this all the time. So we want this to be reliable and robust It's not going to be dependent on other factors such as the way the samples are collected or treatments or centre effects or issues like that. So we're wanting consistency in there. And we're also wanting it to be measured in all patients. We don't want to have severe limitations because it's dependent on having a particularly large volume of sample from individuals, whatever. We want to have a high level of evaluability. And on top of that, we'd like everything to be built upon a foundation of credibility. So this believable story, which is really going from where we're taking this complex initial data to make a treatment decision in the end. Putting this on a sort of statistical framework, there's a well-known sort of formula which I use a lot in statistics. Your total error is equivalent to your combined of your bias and your variation. So if you want to get the correct results, effectively you need to separate these out, make both of these equal to 0. If you've got a situation where you've got a lot of variability, then you're not going to be able to hit the target very often. Similarly, you may have bias in there, so you may be very accurate, but you're also always hitting the wrong result, you're getting the wrong information. And also you want the evaluability. If your shot never reaches the target in the first place, then you can't win anything, score at all. So, what's one of the things we can do there? So, think about the right result or the right science. What can we do improving our chance of success here? Well, one of the issues that often comes up is that we're looking at a huge, potentially a large number of different potential markers that we could be using as diagnostic. And this is potentially true if we're thinking of some of the new technologies which are talking about whole genome scans and proteomics and wide numbers of different potential markers. But can also be true even if you've got a much more focused case and just looking at a limited number of potential markers in the situation. And one of the facts that comes through is that if you have a large number of candidate markers, what can happen is that your true markers, the true things which could identify this, can be lost in the noise, which is just generated by having such a large number of different potential results. So if we're able to actually reduce this down in some sense beforehand, it gives us a much better chance to be able to identify the right markers with a degree of confidence.